Hi there, my highly valued, treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very, very handy in your line of duty. So I take this opportunity to welcome you all to part 104 of our pharmacotherapy MCQ series, majoring in infectious diseases. Welcome. And the first question reads, Mr. NWO, a 25-year-old HIV seropositive male patient, presents to the comprehensive care clinic at your hospital with a chief complaint of new onset fever and several areas of redness on his skin. He informs the physician he noticed some drainage from these areas, which seem to be worsening by the day. This is the first time he is experiencing this, and he currently takes lamivudine, stavudine, and nevirapine, a very old regimen indeed, for his HIV infection, and he also takes fluoxetine for some depressive disorder. And when you probe further, he informs you he has an allergy to sulfur drugs, and the last time he took them, he had a rash. His most current labs indicate good viral control. The ARVs are working, and his CD4 counts are greater than 200. He has a serum creatinine of 0.9 and a BUN of 18. His WBC is elevated, stands at a figure of 11.6. We know that the normal range is between 4.3 and 10.8. We are told that there is a left shift indicating a bacterial infection. His nasal swab indicates he is a carrier of methicillin-resistant Staphylococcus aureus. The physician suspects this is a community-acquired MRSA infection, and he plans to treat Mr. NWO as an outpatient. So my question to you is, which of the antibiotics listed below would be the most appropriate choice for Mr. NWO's treatment now? Would you opt to administer tigecycline, or would you settle for cotrimoxazole, which is Bactrim or Septrin, or would you settle for clindamycin, Cleocin, or would you prescribe or administer linezolid, which is marketed as Zyvox? I'll give you 10 seconds to choose the correct answer. Clindamycin, Cleocin would be the best option for this guy's treatment. Remember, cotrimoxazole isn't appropriate since we are told Mr. NWO has an allergy to sulfur drugs. So alternative B becomes automatically wrong. Giving him cotrimoxazole could cause or increase his risk of SJS, a life-threatening skin rash. So I would not gamble. Now, tigecycline is only available as an IV formulation. There is no oral equivalent. Since we intend to treat him as an outpatient, that would not be an optimal choice. And I would like to add that linezolid will treat this MRSA, but I would call that a little overkill. It's a bit too broad, and it should be reserved for the more resistant forms of MRSA, as seen with, for example, the hospital-acquired MRSA cases, or where the culture and sensitivity would indicate its use. Furthermore, we are told he is on fluoxetine, and we know that linezolid, being a monoamine oxidase inhibitor, will react or interact with fluoxetine, which is an SSRI. Now, this would increase the risks of serotonin syndrome or other possible adverse cardiovascular effects, so it would not be the right choice. And I would just like to add that linezolid is expensive compared to the other oral options that are listed there, and it isn't the best option for Mr. NWO at the moment. That leaves us with clindamycin, which can be administered orally and won't interact with any of the medications this patient is on. Let's move to the next question, please. And it reads, Mr. KCL, an 87-year-old male patient, completed treatment of an initial case of Clostridioides difficile infection 60 days ago, 2 months ago, using vancomycin at a dose of 125 milligrams taken orally via suspension every 6 hours for a duration of 14 days, 2 weeks. His second episode, 30 days later, was also treated with vancomycin. Today, Mr. KCL is admitted with increased bowel movements that are watery. And, given his presumptive diagnosis of a C. diff infection recurrence, my question to you is, which of the therapeutic options listed below would be the best or the most appropriate for Mr. KCL now? Would you opt to treat him with vancomycin at a dose of 125 milligrams every 6 hours for 2 weeks? Or would you treat with fidaxomicin at a dose of 200 milligrams orally once a day for 10 days? Or would you administer vancomycin at a dose of 125 milligrams orally 4 times daily for 10 days, then taper for 5 weeks? Or would you opt for metronidazole at a dose of 500 milligrams 3 times daily for 2 weeks? I'll give you 10 seconds to choose the correct answer. I would treat this case with vancomycin 125 milligrams 4 times daily for 10 days and then taper over a 5-week period. Now remember, fidaxomicin is dosed BD, twice daily, not OD, so that makes alternative B wrong. Then metronidazole is no longer recommended for initial or recurrence of Clostridioides difficile unless it is severe disease where it would be potentially useful in combination with oral vancomycin. I'd like to remind you that the SHARE/IDSA guidelines state that the second Clostridioides difficile infection recurrence should be treated with vancomycin taper and or pulse vancomycin taper. Now, in such a regimen, for the first week, vancomycin would be administered at a dose of 10 milligrams per kilo up to 125 milligrams QID 4 times a day. In week 2, it would be the same dose twice daily. Then in week 3, we would administer the same dose once a day. Then in week 4, we would administer the same dose every other day. Now in weeks 5 and 6, would we administer the same dose of 125 milligrams every 3 days. And that is just to ensure that the Clostridioides difficile is arrested in the spore form, that the spores don't germinate and wreak havoc. Now, the TAPA treatment of recurrent C. diff infection or the CDI diarrhea can include fidaxomicin or orovancomycin. Now, if orovancomycin is used, there is a TAPA involved, as I've just said, after the first initial 10 days. Now, I would just like to remind you that antibiotics usually associated with CDI include fluoroquinolones, clindamycin, and even the cephalosporins. I would just like to remind you that simple things like hand washing with soap and water is more effective than using an alcohol-based hand gel for the removal of C. diff spores. Just remember that. Let's move to the next slide, please. And the next question reads, Mrs. ASV, a 46-year-old Hispanic female patient, presents to your hospital. She has a past medical history of HPV of the cervix, and her chief complaint today is increased urinary frequency and painful urination, which has lasted the past 3 days. And she informs you she took cotrimoxazole, that is ceftriaxone, 60 days ago for a urinary tract infection. And she has no known drug or food allergy. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mrs. ASV now? Would you opt to treat her with cotrimoxazole, levofloxacin, fosfomycin, or ampicillin? I'll give you 10 seconds to choose the correct answer. So I would opt to treat this lady with fosfomycin, 3 grams. Now, fosfomycin, marketed as Moniro, is the only single-dose regimen recommended by the IDSA guidelines for uncomplicated cystitis in women. I'd like to remind you that the IDSA guidelines for uncomplicated cystitis and pyelonephritis state that ampicillin or amoxicillin shouldn't be used for empiric treatment due to their poor efficacy. So that makes alternative D wrong. And I would like to emphasize that cotrimoxazole should be avoided as it was used recently, that is 60 days ago, which falls within the bracket of 3 months for the treatment of UTI. That makes it unsuitable. Then fluoroquinolones such as levofloxacin should only be used when none of the first-line antimicrobials for uncomplicated cystitis is a viable option now. Those first-line drugs include fosfomycin, nitrofurantoin, and cotrimoxazole. I'd just like to remind you that cystitis is an uncomplicated infection involving the bloodline. It's a lower urinary tract infection. Then pyelonephritis is an infection involving the renal parenchyma or tissue, and it's more severe. It can lead to abscess formation. So when it happens, treat it with the seriousness it deserves. Let's move to the next question, please. And it reads, Mr. JPO, a 39-year-old male patient who was recently diagnosed with HIV infection, is admitted to your general medical ward. He has a past medical history of polysubstance abuse, including alcohol. He is in need of highly active antiretroviral therapy due to his high viral load and low CD4 count. He currently takes methadone and disulfiram, which is part of his rehab program. So my question to you is, which of the medications listed below should be avoided in Mr. J. P. O's treatment? Should it be atazanavir capsules, Videx and enteric coated tablets, lopinavir ritonavir solution, or zidovudin retrovir? I'll give you 10 seconds to choose the correct answer. So C, lopinavir ritonavir solution, is the correct answer. Remember, disulfiram, or marketed as Antabius, is an aldehyde dehydrogenase inhibitor used in the management of patients suffering from alcohol addiction. This medication, Antabius, is taken by any patient in an attempt to provide motivation to the patient to avoid alcohol ingestion while disulfiram is present in their bodies. Now, if the patient taking disulfiram ingests alcohol, for example ethanol, it will result in accumulation of acetaldehyde, which will cause significant nausea and vomiting. That will help the patient resist the craving for alcohol. I'd just like to mention that lopinavir ritonavir solution contains 42% alcohol, and it should be avoided in any patient taking disulfiram. So that makes alternative C the best choice. Let's move to the next question, please. And it reads, Mrs. NTJ, a 66-year-old female oncology patient with stage 2B breast cancer, presents to the oncology clinic. Some of her pertinent labs include an absolute neutrophil count, that is ANC, of 350. A routine urinalysis reveals over 100,000 colony-forming units per ml of Candida albicans. So my question to you is, which of the therapeutic options listed below would be the most appropriate for NTJ's treatment now? Would you opt to treat this candiduria with flucytosine, micafungin, fluconazole, or is it true that no therapy is indicated at the moment? I'll give you 10 seconds to choose the correct answer. So fluconazole is the correct choice. Now, I would like to start by saying that severely immunocompromised patients should be treated for asymptomatic candiduria. And fluconazole is considered the drug of choice because it is primarily excreted in urine in its active form, and urine concentrations easily exceed the MIC of most Candida species isolates. Most other antifungals, such as the other azoles, echinocandins, have minimal excretion of the active drug into urine, and that makes them unsuitable choices. I would just like to add that flucytosine is used to a very limited extent due to its hematologic toxicity and the development of resistance, especially when used as monotherapy. So it would be a non-starter in this particular clinical scenario. That makes alternative C the best answer. Let's move to the next slide, please. And it reads, Mrs. TKM, a 67-year-old female patient, was admitted to your hospital a week ago after an acute myocardial infarction. Some of the oral medications she takes chronically include metoprolol, aspirin, lisinopril, glyburide. And she has a temperature Her maximum body temperature, for the last 24 hours was 102.1 degrees Fahrenheit. The WBC was 15.4 times 10 power 3 per microliter, and the infectious diseases consultant on duty initiates linezolid IV and piperacillin tazobactam IV after this patient's blood is sampled for culture and sensitivity. 48 hours later, her blood culture is positive for Candida albicans, and the sensitivity data is still pending. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mrs. TKM now? Would you choose to treat her using liposomal amphotericin B infused over 4 hours, or would you infuse micafungin 100 milligrams over an hour, or would you administer fluconazole, or would you choose to treat her with voriconazole? I'll give you 10 seconds to choose the correct answer. So I would choose to treat this lady with fluconazole. Now, any of the listed agents should provide coverage for Madam TKM's Candida albicans fungemia. However, voriconazole can be used as a step-down therapy from amphotericin B or for mecanocandim for species with increased frequency of fluconazole resistance, such as Candida glabrata, for example, or Candida krusei. Now, echinocandins are typically reserved for patients who are critically ill in the ICU and who have received prior azole therapy, or those who are infected with azole-resistant isolates. That data is still missing, so I would comfortably use fluconazole as I await lab results. Let's move to the next question, please. And it reads, Mr. FKO, a 55-year-old male patient weighing 100 kilos, was admitted to your general medical ward. His blood cultures have returned positive for Candida albicans. The infectious diseases team has decided to initiate therapy using fluconazole. Some of his pertinent labs include a BUN of 18 and his serum creatinine is 1.1. So my question to you is, which of the dosing regimens listed below would be the most appropriate for Mr. FKO now? Would you choose to administer 800 milligrams as a loading dose, as a start dose with no loading dose, or would you administer 400 milligrams once daily without requiring a loading dose, or would you administer a loading dose of 1,200 milligrams start and then followed by 600 milligrams once daily, or would you load with 400 milligrams start then continue with 200 milligrams? I'll give you 10 seconds to choose the correct answer. I would load with 1,200 milligrams followed by 600 milligrams once daily. Now, the IDSA guidelines recommend using fluconazole at a dose of 12 milligrams per kilo loading followed by 6 milligrams per kilo once daily for treatment of candidemia. Remember, this gentleman weighs 100 kilos. So the arithmetic is pretty simple. Now, this recommendation is supported by studies demonstrating an association between suboptimal that is below the 6 milligram per kilo per day dose, and worse clinical outcomes such as death and even microbiologic outcomes such as increased risk of azole-resistant isolates. So you have to get your dosing right to avoid cases of azole-resistant isolates arising or increasing chances of mortality because of getting the dosage wrong. Avoid dosing such patients below the 6 milligram per kilo per day dose after loading. Let's move to the next question, please. And the next question reads, Mr. JKL, 49-year-old male patient, is being managed for bacterial infection in your general medical ward. Today, his creatinine clearance is 40 ml per minute. So my question to you is, which of the probable therapeutic options listed below would require a renal dose adjustment if the infectious diseases team opted to use it in Mr. JKL's bacterial infection during his admission to the general medical ward? Would it be isavuconazonium, which is marketed as Cresemba, or would it be tedizolide, marketed as Civextro, or would it be ceftolozane tazobactam, marketed as Zebraxa, or would it be oritavancin, marketed as Obactiv? I'll give you 10 seconds to choose the correct answer. Ceftolozane tazobactam, Zebraxa it is. Now, ceftolozane tazobactam is a cephalosporin co-formulated with a beta-lactamase inhibitor, which is administered intravenously via infusion. It requires renal dose adjustment in moderate renal impairment. And I'd just like to add that severe renal impairment and even end-stage renal disease patients on hemodialysis also require dose adjustment when they are on it. Now, isavuconazonium Cresemba, which is alternative A, is an azole antifungal which can be administered orally or IV, and it requires no dose adjustment in renal impairment. That makes answer A wrong. And then oritavancin, Obactiv, is a lipoglycopeptide antibacterial agent which is administered intravenously, and it requires no renal dose adjustment in mild or moderate renal impairment. So that makes alternative D wrong. And then tedizolide, which is marketed as Civextro, is an oxazolidinone class antibacterial agent that is administered both orally and intravenously via infusion, and it requires no dose adjustment in renal impairment whatsoever. So all those many words qualify C as the correct answer. Let's move to the next question, please. And it reads, AKL, a middle-aged patient, was admitted by the infectious diseases team to your general medical ward. Empiric treatment for meningitis was initiated using ceftriaxone and vancomycin as per the IDSA guidelines. Today, his CSF returned positive for Treponema pallidum. So my question to you is, which of the changes in therapeutic management listed below would be the most appropriate for ALK's case now? Would you discontinue vancomycin and continue ceftriaxone? Or would you choose to discontinue vancomycin and ceftriaxone and initiate penicillin G? Or would you discontinue vancomycin but choose to continue ceftriaxone and initiate penicillin G? Or would you discontinue ceftriaxone but continue vancomycin and initiate penicillin G? I'll give you 10 seconds to choose the correct answer. So I would opt for either A or B. Now, although ceftriaxone will cover Treponema pallidum in cases where many of the etiologies of a suspected CNS infection is considered, penicillin G is the drug of choice. Now, once identified, Treponema pallidum neurosyphilis should be treated with any of the following: penicillin G 4 mega units every 4 hours, or penicillin G via continuous infusion over 18 to 20, at a dose of 18 to 24 units every 24 hours. Or you can even also use ceftriaxone as an alternative to penicillin G. I'd just like to add that neurosyphilis caused by Treponema pallidum commonly occurs in latent syphilis. However, it can also occur at any other time in the course of infection. So be very, very cautious. Now remember, penicillin G should be considered a high-risk medication due to the risk of confusion between the different penicillin G formulations. There are many cases where benzathine penicillin G, procaine penicillin G, and the crystalline form may be mistaken for the other because of the fact that they sound alike. I'd just like to remind you that penicillin G benzathine can be used in all stages of syphilis except neurosyphilis because it has to be administered IM, and very low concentrations will be obtained in the central nervous system. Let's move to the next question, please. And it reads, Mrs. BLM, a 44-year-old female patient, presents to your hospital. She has a chief complaint of increased urinary frequency and painful urination, and she also has flank pain, which has persisted for the past 72 hours. She has no known drug or food allergies, and she received a prescription for cotrimoxazole, 1 double-strength tablet orally twice daily for 14 days. The resistant rates in her community is unknown. So my question to you is, which of the recommendations listed below would be the most appropriate for Madam BLM now? Is it true that cotrimoxazole is sufficient alone? Would you opt to administer ertapenem as a start dose? Would you choose to administer ceftriaxone as a start dose? Or would you administer tigecycline as a start dose? I'll give you 10 seconds to choose the correct answer. C is the correct answer. A single or a start dose of ceftriaxone would suffice. Now, the IDSA guidelines for uncomplicated cystitis and pyelonephritis state that a start dose of ceftriaxone and a consolidated dose of an aminoglycoside should be used for patients with pyelonephritis when cotrimoxazole resistance rates are unknown. Ertapenem would provide excessive antimicrobial coverage and is not addressed in the IDSA guidelines. And then tigecycline should be avoided as it has very poor urinary penetration and there is no data concerning its use in urinary tract infections. So I would not use those. I would settle for ceftriaxone single dose. Let's move to the next question, please. And it reads, Mr. ZNB, a 37-year-old male patient, presents to your infectious diseases clinic with uncomplicated cellulitis. He has no known drug or food allergies. He currently takes multivitamins once daily after his breakfast and also relieves his joint pain with naproxen pro renata when necessary. My question to you is, which of the options listed below would be the most appropriate for Mr. ZNB now for the management of this cellulitis? Would you opt to use cotrimoxazole, Septrin, or Bactrim? Would you choose to use cephalexin, or would you settle for linezolid, Zyvox, or would you choose Avelox, moxifloxacin? I'll give you 10 seconds to choose the correct answer. I would settle for B. Cephalexin is the correct answer. Remember, Mr. ZNB needs coverage for streptococci, which primarily cause uncomplicated cellulitis in most patients. Acceptable agents according to the guidelines include, for example, dicloxacillin, cephalexin, clindamycin, and even erythromycin. Since resistance amongst this gentleman's community is not common. Now, Staph aureus is a rare causative pathogen in cellulitis, except in those patients that are have an underlying abscess or some form of trauma. So I would not cover for MRSA with the linezolid, which is alternative C. All those many words make B the correct answer. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, and to share it widely with your peers, and to leave a comment at the bottom of the video. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. I sincerely thank you very much for viewing this video and for listening to me. And I highly appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in the next video. Thank you.